All right, so we figured we'd do this explainer video to just sort of walk people through the black box of how we got at this. So I think we'll just do this as a conversation, guys. Does that make sense? Perfect. So, Zarek, what are we maybe start with the question? Like what's the goal of the paper?
Yeah, I mean, of course, all papers have a big overarching goal. I think when I think as health economists, we've been steeped in this for a long time, and we know, even if you're sort of a casual viewer of the healthcare industry, you know that spending on healthcare has been rising tremendously for the last, maybe half century.
Yeah.
And we know that for most people in the US, most working age people in the US, how does that healthcare get financed? It's financed through insurance that you have through your employer. And that creates this linkage that economists have thought about a little bit between things that happen in the healthcare market and things that happen in the labor market for working age Americans. And so, back when we had a conversation at U Chicago,
Yeah, no,
uh,
we had this in what, like 20, it was like
April
28,
April 2019.
2019.
Uh,
Okay, so it took us 5 years to get this
yes,
paper done.
yeah, for a long time, I think I had felt this way. I
Lev had
mentioned
just
you
been
felt this way
born,
too.
right, Lev?
That's right. Yeah,
Yeah,
2027 when I was
yeah,
born.
we just
I think for a long time we thought about, the so I think Zach you'd spent a lot of time thinking about there's all these ways in which prices are driving rising healthcare spending and differences in healthcare spending across the US. I was just graduating from my PhD. I'd been thinking a lot about, to what extent this like connection between healthcare and labor market had implications for the labor market. So back in April 2019, we sort of had decided to put this together. And the idea that we thought about is like, to what extent do these trends of rising healthcare spending, how do they affect labor markets? How do they affect sort of the labor market opportunities for working age Americans? Um, and that, of course, as we've talked about, required a 5 years of effort, right?
right.
Uh, so I think the way I think of this is a sort of a big study where we're gonna we're going to track changes in healthcare spending and think about how those filter down into affecting people's labor market opportunities.
Yeah, I mean, I think fundamentally it's this question of who pays for rising healthcare prices in the US. Like, can we track those through and see at the end of the day who's the residual claimant on the cost of the price increases?
It's always good to sneak your title into the
Yeah, no,
fascinating
exactly.
conversations
And I
there.
realized we didn't introduce ourselves. So Zarek, do you want to give a quick intro and Lev
Yes,
and
yes, of course. I'm Zarek Brot-Goldberg. I'm a professor at the Harris School of Public Policy at the University of Chicago. And like the other two on this call, I've spent many years thinking about healthcare policy.
all right, Lev.
My name's Lev Klarnet. I am a PhD student at Harvard, uh, and have been working on this project since around 2020.
Perfect. And I'm Zack Cooper. I'm an associate professor at the Yale School of Public Health and in the Department of Economics at Yale University. So I guess for both of you, why is it hard to get a causal, we want to get a causal estimate here. So rising prices cause this. Why is getting causality in this setting tough? And maybe Lev will have you kick this off.
Sure. So a major challenge is if you just wanted to look at the places that saw the biggest increase in healthcare spending or healthcare prices and try to look at what happens in the labor market, you're unlikely to get a causal effect because there's many things going on in the labor market that themselves impact healthcare spending. And the most obvious is when people get richer, they consume more healthcare. So they're more likely to go to the doctor. And as a result, you might find that rising healthcare spending looks like it actually increases wages when in fact the reverse is what's happening. So what we needed in this project was a shock to healthcare prices that was random. It wasn't driven by anything going on in the labor market and was discrete enough for us to be able to measure, to detect a measurable change in what feeds through into the labor market outcomes.
And
Yeah,
we
let's
decided
be
to use hospital mergers as the shock to prices. Zarek, I think like the obvious question is why didn't we just compare places that had a merger with places that didn't?
Yeah, I mean, backing up even, I think economists are obsessed with causality to an extent that may drive a normal person insane. Right? I think it's very natural to just think about, comparing places where healthcare spending went up, or just comparing places where mergers sort of happened and didn't happen. The problem is, of course, the world is so complicated. So, for instance, we could think about comparing places with mergers and no mergers. It turns we spent
Years.
2-3 years,
Yeah.
2 or 3 years trying to do that, and we're stymied by the fact that it turns out that if you look at a map of where hospital mergers have happened in the last 10 years, it's essentially pretty much a map of the US, absent maybe Wyoming and North Dakota. And it turns out it's really hard to think about a way to compare Wyoming and North Dakota to Chicago and New York.
It was basically any place
so,
that had a hospital experienced a hospital merger.
Pretty much. And so, except for the exclusions are some farmland or some national parks out in the West. And so, that was a big problem for us, right? So what do you do when everywhere in the US is experiencing these sorts of mergers? And so the way we thought about it is we thought about, look, there's some parts of the US that have more merger, what I call more exposure to mergers than other parts of the US, right? So, you might think of one city, so let's call it city A, where there was a merger, but there was only one, and the merger didn't really result in such large price increases. And so even though it's a place that we might call treated in the sense that it's had a merger nearby, it's not as treated as, say, city B, where there were 5 mergers and they really consolidated the hospital market. And so prices after these mergers really skyrocketed. And so rather than thinking about places with mergers and places without mergers, we're going to think about places with a lot of mergers or with really sort of price increasing mergers versus places where mergers didn't seem to do all that much to healthcare prices.
And so why are the price effects of mergers varying? Like why are some mergers leading to bigger price gains than others?
I feel like I should be asking you that question, not you.
Yeah, no, it turns out that if I'm an expert in anything, yeah, I know very little, but it turns out I know the answer to that question. No, I'll let you.
I think we should cite Cooper et al. 2019.
Yeah, I mean it's basically like the spatial distribution of hospitals. Like when 2 hospitals that are merging are close together, they're viewed as close substitutes by consumers. That is, they'd be willing to go to either one. And do in practice, those mergers generate the largest price increases. Lev, your light turned out. This is like life as a PhD student. You're not paying your power bills.
It's true.
Yeah, I see darkness now.
I'm not sure they treat the PhD students at Harvard well enough.
Yeah, no, seriously.
But to follow up, it's true, right? Mergers are not created equal, right?
Yep.
There's some mergers where we think of the reason that hospital mergers raise prices is because prices for hospitals are often bargained over between hospitals and insurers. And so, the extent that the hospital gets a better price is all about, bargaining strength of the bargaining table, right? What can you, how long are you willing to hold out to get a better price? And, what's your sort of threat if you decide to walk away from the bargaining table? And so, a big part of that is substitution, right? So if you have 2 hospitals that are super close together and now they merge, now if I'm an insurer, I have to deal with both of them at once. And if I lose both, that's really bad for me. And so, some of these mergers, as you said, create these big price increases because the hospitals are so complementary to one another. That when they bargain together, they can get big gains. And some of them, they're farther away. Same people don't really want those 2, and so they don't result in such large price increases. Of course, in Zack's prior work, both Zack's prior work and prior work from the 3 of us with our co-author Stuart Craig, we document that yet again.
And I
Um,
think the other is just the aggressiveness of certain managers. I think you call it aggressiveness, call it savvy, whatever you want to, whatever term you want to use. It's just going to be some CEOs who really are exploiting the full market power that they have. Others who, for whatever reason, are choosing not to. So that's really the variation. I mean, the
yeah,
way I think about it is, you've got one town in Connecticut, or actually one company, whose workers are all going to Yale New Haven Hospital. And Yale New Haven Hospital merges with our closest neighbor, which we did, St. Raphael's, and prices go up by a lot. And so that company whose employees all go to this one hospital are going to be very, very exposed to the price increases of that merger. And you can sort of juxtapose that with a firm in New Haven who's got workers all over the state. And even though the company might be near Yale New Haven Hospital, its workers are sort of spread, and not all of them are going to Yale New Haven. So you can have one firm that's really, really exposed, one that's not. And in a sense, what we're doing is comparing those two.
yeah, it's something that also took us many years to think about hard, which is that it's not just about places, right? It's about even for two employers in the same city, their workers live in different places, and so the exposure of specific employers to different hospital mergers is very different.
So Lev, yeah,
Um,
walk us through
and
the data. Oh no, sorry, I cut you off, Zarek. What were you gonna?
I was I was gonna ask, I know I was gonna say the same thing. This is a big undertaking for all of us, and you guys, the two of you really did a lot with Stuart, did a lot to manage the sort of data flow. So
Yeah, I
I'm
don't even
happy
know
to
that I'm
talk
going to take
about
credit
talk
for it. I
about
think
that data.
this is Lev. Yeah, what's the data lift, Lev? What are we working with here?
Yeah, data and measurement on this is really challenging because we're combining together a lot of really private data. So the data for healthcare prices is all coming from the Healthcare Cost Institute, which measures private transacted prices between insurers and providers.
So it's going
Crucially,
to capture about a third of individuals in the U.S. with employer-sponsored coverage. It's going to be folks with coverage from Aetna, Humana, and United Health. So a pretty big chunk of the market.
yeah, and then we connect that data up by via geographies to and through employers to Form 5500s data on insurance premiums for thousands of employers, and then
And
IRS
that's
data.
that's collected by the Department of Labor and I think the IRS together. So that's a government form.
Yeah, that firms of a certain size all have to fill out, and
Yep.
then we use IRS data to look at individuals' wages, where they work, the taxes that they pay, and whether or not they've received any unemployment, which we use to measure flows into unemployment.
Yep. So we got the universal tax returns. We got a huge chunk of insurance claims data. And then we've got insurance premiums for a subset of firms. So the first thing we did was identify firms in the data, in the IRS data. And we should say we're working with economists at the US Treasury and the IRS. We're actually not seeing the tax data ourselves. It's all through a formal program set up by the IRS and Treasury that allows research on tax data. We're going to build a database of firms over time. It was 150,000 companies. So we're going to do that. And then, what are we going to do once we have the database of firms, Zarek?
Yeah, so we're going to think about for each of these employers, we're going to think about their specific exposure to mergers, right? So that's going to vary across all these employers. In the way you talked about earlier and I talked about earlier, which is employers are in different places, and so different places have more mergers or bigger mergers, and then even in the same place, different employers have different exposure to these mergers based on where their employees live and where their employees, given where they live, are likely to seek care. And so we're going to say, okay, there's all these different employers, and we're going to track them over time from 2009 to 2017. We're going to say over time, these mergers happen. And so now that raises the costs of healthcare spending for this employer is likely to have to pay. And we're going to ask, okay, to what extent does that seem to be contemporaneous with changes in how much the employer is paying their workers, how many workers they're retaining, these things across time and across these employers.
Informally, this is, we're going to call this a measure of simulated spending. It's going to be a shift share instrument. So for every college student out there who's just finished metrics, right? This is a shift share instrument. Is that going to be the best way to describe it, guys?
Are they teaching shift share in undergrad now? I worry.
Yeah, I did not get that in my undergrad. I don't know, Lev, when did you get shift share?
I did. We covered it briefly at the end of the first year of the PhD. So I think
okay. So
some excellent undergrads out there are going to know what we're
right.
talking about.
Okay. So this is for our first year PhD students.
The way to think about it is we want to say, look, there's lots of reasons that spending changes across time and space. And we're going to isolate the likely changes in healthcare spending that are going to arise as a result of the accumulation of hospital mergers across space and time. So we're going to say, okay, we know from prior estimates that we put together in a previous paper, for every hospital merger that happens over this period, what was the effect of that hospital merger on prices? And then we're going to say, okay, given where you live, given the baseline prices at the hospital, we're going to expect that you were going in some amount to that hospital. We're going to say, okay, given that the price goes up by 5%, we expect your total spending to go up by X%. And so we, and by we I really mean Lev, are going to aggregate all these individual hospital merger effects across space and across time and say, for every employer, how should we expect healthcare spending for that employer to go up as a result of these mergers, right?
And so I think the question we get asked all the time is, how do we rule out other things happening? Like, maybe mergers are happening in areas that are exposed to trade or experiencing economic decline. What's our approach there?
Yeah, I mean, the worry you'd have is, why are these mergers happening, right? You might really worry that there's parts of the U.S., especially coming out of the Great Recession, where regions were in economic decline, and maybe that's where mergers happen. And you wouldn't want to say, what we're relying on is that we see healthcare spending go up due to mergers. We see, in our case, employment go down and payroll go down. We're going to try to convince you that that's because of the mergers, but you should worry maybe that other things were going on at the time, right? You'd really worry that areas in economic decline see these mergers. And so, we have a lot of tests, and we can maybe each of us can say one in turn.
As long as I don't have to say the B&H correction.
One test of this is, imagine a merger happens in 2012. That should affect things in 2012. It should affect outcomes in 2013 too, but it definitely shouldn't affect outcomes in 2011 before everything even happened, right? We shouldn't expect causality to go back in time. And so one test is, if you thought that exposure was because places were in decline, then you'd expect to see things that look like mergers are affecting outcomes in the years before they happen. And so we construct a test that looks exactly like that, which is, if a merger happens in a given year, does that seem to affect outcomes the year before? And luckily, the answer seems to be no. But it could have been true otherwise. Now, that's one, of course, of a panoply of tests, right, Zach? We've also thought about, finding specific spots, right?
Yeah, I mean, my favorite, well, Lev, you can tell them my favorite, or I think my favorite.
I'll take a guess. I think so. We do a ton of tests where we throw out different sets of counties. So we exclude, a quarter of U.S. counties based on a variety of things. One, the counties most exposed to trade with China. Another being, counties with the lowest income, the lowest trends in income. All of these tests, we always get the same result, no matter what subset of counties that we're using. So it doesn't look like it's driven by any of our results are driven with any kind of any relationship with trade, with declines in income or declines in employment prior to these mergers. So that makes me a lot more comfortable.
And I think the last point that maybe we want to double click on is this question of magnitudes, right? It sort of first blush, it seems pretty crazy that a 1% increase in healthcare prices is going to lower firms' payroll by 0.4%. So maybe just like talk us through how we tested for that, Zarek, and scaled that up. I mean, I think what gave me comfort is everything sort of adds up, but walk us through.
Yeah, it's sort of funny to think about. Healthcare, I think what people often forget, even we might forget once in a while, is that healthcare is a huge part of worker compensation, especially at companies that tend to offer health insurance benefits. And so, for instance, I think some of the most recent numbers are, health insurance benefits represent something between 8 and 10% of healthcare compensation for workers.
Yeah.
Right. So you can imagine that, the average worker, say take a worker who's paid $25,000 a year in wages. Well, they might be receiving health insurance benefits that are cost about, let's say $3,000 a year on average, right? And that's a huge part of their compensation. And by the way,
and it could even be higher, right? Because that's an average, right? So for the CEO, it's a tiny share. It could be a premium that's 8,000 for the person making 25,000.
Yeah, I think one number that you've always passed around me, Zach, is that I think you could be spending up to that's thinking about one person. When you count a person, their spouse, their dependents, their kids, you could be getting up into the tens of thousands. I think the number we have on average is it comes
24,000 for a family of four. It's $24,000. So a new Toyota Corolla is the line I use all the time.
Yeah, and that's a huge part. That of course that includes lots of different types of people making lots of different types of wages. But think about it, if you're a low wage worker, that's a huge part of your compensation.
Yeah.
Right. If you're and so when you think about even a 1% change in that's about $240. Right. That's actually a big, that's about on the order of 0.5% change in your sort of total compensation or your wages. And therefore, it's not that crazy to think, well, if healthcare spending goes up by $200 per person, we're gonna have to cut wages by $200 per person. And that starts to add up as the cost of healthcare grows even higher than 1%.
Right. And you start summing that up. And, I think what we're seeing in the paper is they're not lowering people's wages, they're letting workers go. And so eventually you sort of sum those up across workers. And for a firm with 200 employees or 1,000 employees, eventually you get to sort of, whole numbers of workers who get, separated from their jobs.
Yeah. I mean, you love the Corolla example, which I also love. My also favorite example is that what we find is that 1% change in healthcare spending is pretty close to akin to you could think of it as the hospital as taxing employers, akin to a payroll tax of about 1 to 1.5%.
Yeah.
And so this is sort of it's a big order of magnitude, but it's not that crazy in a world where healthcare spending is a really big part of compensation.
No, exactly. So I think that's a pretty good summary for folks of the data we're using, the question we're trying to answer, and broadly the methods. I think if folks have questions, you can certainly email the three of us, send Lev the really hard questions, and I think I hope this gives folks an insight into what's under the hood of the paper that we just released. So thanks, guys, for doing this.
Yeah.
All right, we'll talk soon.
Bye.